Good afternoon. This is Marie McPherson for the Center for Behavioral Health Improvement and Solution in the College of Behavioral and Community Science at the University of South Florida. Today, in the first of a series of conversations on the state of behavioral health services in Florida, I am speaking with Dr. Nick Abid, Pharmacy and Behavioral Health Medical Director at Sunshine Stay Well Health Plans, where he first worked with the pharmacy division and more recently with the Florida market and its behavioral healthcare managers internally. Dr. Abid also works closely with community mental health providers and inpatient behavioral health facilities to ensure mental health services for over 2 million members in the Medicaid, Medicare, and public markets. In his role, Dr. Abid is responsible for ensuring that 800,000 Florida Medicaid and over 100,000 seriously mentally ill members receive quality behavioral health care services. Dr. Abid also serves on the board of NAMI Florida. In all of his role and his prior experience, Dr. Abid has committed to improving the life of the population he serves. Although we could discuss many topics today, but given your experiences practicing in both community psychiatry in large hospitals and community mental health centers, and for the last 15 years in Medicaid managed care environment, I would like to focus first, and based on your experience, how has the practice of psychiatry evolved over the last 2 to 3 decades? And specifically, how has the role of a psychiatrist changed now that other professions, I'm thinking psychologists, psychotherapists, clinical social worker, neurologists, and more recently primary care providers have entered what was the traditional role of a psychiatrist? Is the psychiatrist an endangered species? Is this a profession in crisis?
Well, I don't think it's a profession in crisis. I think it's a profession that's actually growing and thriving, and the slots in the psychiatry residencies across the country are filling up rapidly. They don't have any empty spaces. So I think more and more people are becoming interested in psychiatry. When you think about where we've come from, Marie, we've come a long ways from the 40s when psychoanalytic psychotherapy was the mode of treatment for those people who could afford it, right? They'd go 3 or 4 times a week and get psychoanalytic psychotherapy lying on the couch. And if you had a serious mental illness, you ended up in the state hospital, and you could be there weeks, months, maybe years. And each state had multiple state hospitals across the country, right, that would basically house these people because they didn't have psychotropic medications. And then in the 1950s, there came the development of the antipsychotics like Thorazine. And really, some people liken it to the development of penicillin for infections. It was such a revolutionary thing. It made a huge difference in the treatment of people with serious mental illness, right? So all of a sudden they had a treatment. Antipsychotics became more widely available, and people could leave the state hospitals and go home. And that's what we saw in the 60s was the deinstitutionalization of the state hospitals. And actually, most of those state hospitals now have closed as a result of the development of antipsychotic, antidepressant, anti-anxiety medications that make a huge difference in the lives of people with significant mental illness. So, I mean, I think we've seen a huge transition, right, from the days of state hospital to community-based psychiatry services. And I would say it equals what's happened in infectious diseases in terms of dramatic changes in the way we live our lives. And in the 70s and 80s, we saw the onset of the use of stimulants for children with ADHD and antidepressants for severe depression. And when I came into practice in the 1980s, that was when the first DSM-1 came out. We've had 5 versions of the DSM-1 since, and really what it has done is it's standardized the nomenclature for mental illness. And so all psychiatry, psychology, social work people have a common base of nomenclature and understanding for the diagnosis of psychiatric conditions. Now, another huge advance. So, and now more recently, people like you, we've had practice guidelines that are just tremendous benefit to primary care physicians who basically treat about 80% of the general mental health issues of their patients, like anxiety and depression. Those guidelines that you've produced every year for a number of years have been absolutely essential to helping these physicians understand treatment modalities, best practices, and so forth. So now we know, and the research shows that talk therapies and medication therapies combined is probably the very best way to treat people. You can't just give patients a pill and expect them to get better. Really, the medication is just a part of a larger treatment plan that involves individual therapy, milieu therapy, family therapy. So in so many cases with kids, there's family dynamics going on. So I think we've made a huge advance in mental health services over the years, from my point of view, from when I first started in practice to now. So
it sounds like, as you mentioned, that the Woody Allen type of endless psychotherapy that era is gone.
Well, it's still available, and some of the, it's still available to people who can afford it. But at least for people in Sunshine and Stay Well managed care programs that serve Medicaid and Medicare populations, they have mental health issues that really probably aren't appropriate for psychoanalytic psychotherapy, which is basically used for people who have neurotic conditions. But more serious depression, anxiety, panic disorders, thought disorders, folks with those conditions, domestic violence, severe marital dysfunction, alcohol abuse, and so on, they need a more traditional cognitive behavioral therapy, that kind of thing, plus medication. So psychoanalytic therapy is meant for just a very select, small group of people.
Yes, I see that. So, it's kind of well known right now that we have some serious shortages of both child and adult psychiatrists in Florida and pretty much all over the country. I mean, Florida is not alone. Long waiting time before securing a psychiatrist appointment are common complaints from both the referring primary care provider and the patients. How is your organization reacting in filling this access gap, and especially in rural areas where these shortages are most pronounced?
Well, that's absolutely the case, that there's a nationwide shortage of child and adult psychiatrists as well across the country. And I think that's partly due to the fact that reimbursement for psychiatrists was so low for so many years. Pediatrician, internist, psychiatrist, generally the cognitive therapies where they don't do procedures were generally paid quite a bit less than people who do procedures like orthopedic surgeons and so on. So, but I think there's been a resurgence of interest in psychiatry, especially now with all the advances in MRI technology, CT technology, brain scanning. There's a new awareness and new interest in the neuropharmacology of mental illness. And like I was saying, most of the psychiatry residency slots are filling up now. And students, I think, are interested in working with younger people. And that's what psychiatry is all about. It's working with younger people in the thick of their lives, right in the central part of their lives. They have family problems, they have marital problems, they have substance abuse problems, they have work-related problems. And so when I have students with me, they say, geez, you work with a lot of young people and young adults and people in their 40s and 50s, not necessarily geriatric people. Like internal medicine works with a lot of folks, with elderly folks with heart disease, diabetes. So there is a growing interest, and I think resurgence in psychiatry as a profession.
Well, what we're doing, really good to know. That's good to know, especially in view of the low reimbursement rate in the Medicaid environment, where perhaps the incoming psychiatrists are probably thinking, well, I probably do best working in a private practice or within commercial insurance, which still leaves that Medicaid population in dire strait in terms of accessing behavioral health services.
When I first started in practice, I accepted all forms of insurance, Medicaid, Medicare, and I consulted at the mental health center, and I had my private practice in another part of the neighborhood, right? And if people didn't have any kind of funding whatsoever, I saw them through the community mental health center, where I was a consultant for many years. So I kind of was able to take care of anybody who needed treatment, independent of their payer source. And more recently, when I was at Cape Cod Healthcare in Massachusetts, we developed an RVU system where the doctors were, their productivity was measured by an RVU system that was agnostic to the payer source. So if you took care of someone with no coverage whatsoever, it received equal weight to someone who had coverage with Medicare, Medicaid, or commercial insurance. So those are a couple of ways that people have coped with the reimbursement issue. But, I do think that psychiatrists now, many of them that are in private practice, and it's a diminishing number that are in private practice, won't accept any insurance. They just accept cash. And so that can be a big barrier to people getting the health care they need.
Yes.
And the other person who doesn't go into private practice joins a big corporation, whether it's a big hospital system or whatever, and those folks are on a salary, and then they go, I think there's more of a tendency to expect that you're going to work 9 to 5. I had a recent communication with a big health system here in the Tampa Bay area, and they hire an outside agency to do all the after hours and on weekends, and their doctors just work the 9 to 5, Monday through Friday kind of thing, which is, for me, was unheard of in private practice. I was at the hospital at 7 in the morning and doing a consult in the ICU, and I didn't get done until 7 or 8 at night, when I have to go back to the hospital and see somebody who had been admitted during the day. And then I had to do an evaluation of before they went to bed, so make sure that they were safe and all of that.
So that's part of the way the delivery of behavioral health services are rendered. Also, another big change is that in order also to fill the gap in the shortage of psychiatrists, is primary care providers are increasingly assuming a greater role caring for patients with behavioral health conditions, in a way filling up the shortage of psychiatrists. Despite many efforts towards integration, we know that silos are still prevalent, where behavioral health and primary care, physical health are still not well integrated, and social services, so important to recovery, are not well linked either. Where do you see are the opportunities in achieving progress towards integration of behavioral and physical health and community linkages with community services?
Well, it's interest. It's you know, that's the next evolution of psychiatry is integrated care. You're talking about 2020 now. We talked about the history of psychiatry and where it's evolved to. You're hitting on what we're doing right now in 2020 to improve mental health services, because as you said, so many of our patients with mental illness, mental health problems have high blood pressure, diabetes, they have obesity, they have high cholesterol, and they virtually all smoke. So they have COPD, and they have a lifespan 20 years less than the average person. And for years and years, mental health services were treated in one building, and medical services were treated in another. And for the first time, we have mental health service and behavioral health medical services coming together, which is a really exciting thing. Like you said, primary care does do 80% of the mental health services for their primary care population. They prescribe most of the antidepressants, most of the anti-anxiety drugs, and they're now hiring social workers, psychologists to work in their office and provide collaborative care as they treat these people, which I think is a real advance. Mm-hmm. We have what we call primary care homes. And in these homes, they're designated if they have mental health services, social work services, psychology service, they can be designated as a primary care home. And we have over 700 of those in our network here at Centene. And we have also behavioral health homes, which are mental health centers, our traditional mental health centers like Appalachia Center, Peace River, Citrus Health. They have brought primary care practices into their mental health center. So people with serious mental illness, for the very first time, get their care integrated in one site. And I think it's going to make a huge difference over time for those people if they get their mental health treated and their minds are clear and their thinking's clear and their decision making is better, then they can follow through on their medical care, like taking blood pressure medication, taking their cholesterol medication, all of that stuff. So well, I think those are things that are happening right now in the mental health world that are exciting and going to make a huge improvement for patients.
But do you see also a way, since primary care providers are more and more involved in treating, perhaps not very severe behavioral health conditions, how would you say that perhaps additional training of these primary care physicians is probably wouldn't be a bad thing, because their training is not especially in addressing mental health issues?
I'm of the opinion that every primary care resident should do rotation in psychiatry and mental health. And you asked, what are we doing to promote the development of psychiatrists? I've been teaching at Nova, the Patel College here in Clearwater. I taught psychopharmacology and treatment of schizophrenia and that kind of thing. And we try to get the students excited about psychiatry by being involved in teaching. But I realized that out of that, that 200 students in that class, the vast majority of them will go into primary care. So we do want to give them a good background education in mental health services and what that's all about. And we're trying to promote clerkships, 6-week clerkships for the medical students in 3rd and 4th year, so that they get a real good handle on mental health services. And for primary care residents, they should all be required to do a rotation in psychiatry. So as you said, they have some greater understanding of mental health. How early diagnosis is like key to treatment, right? And so that's what primary care physicians do. They screen patients, identify early signs of mental health problems, and try to nip those in the bud before they get to the point where they need a referral to a psychiatrist.
Substance abuse also features prominently, in primary care net offices. And do you feel that primary care providers are also sufficiently or well also trained in dealing with substance abuse problem? Because they do see quite a few of these patients. I mean, that's where they're the first gatekeepers sort of thing. That's where those problems are first identified. So as you said, and I really strongly believe that extended training for primary care provider in both mental health and substance abuse treatment, or diagnosis and treatment, and to be able to say, that's it, I can't, it's beyond my current competency, I need a psychiatrist treating this particularly difficult patient. So there is also the recognition on the part of the primary care providers that when their skills are to be, the referrals are needed.
I think there's a resurgence of interest in mental health education in the primary care setting. When I go to primary care meetings like the osteopathic meetings and so on, we see that they have lots of in-services on mental health topics now. And I think primary care physicians are clearly aware that like a third of their practice is mental health related in one way or another.
Wow.
And so, yes, like 1/3 of their practice will be depression, anxiety, panic disorders, somatoform disorders, people that have chronic pain with a psychological, component to it. And so they're getting a lot of in-services through their professional organizations around mental health in postdoc programs.
Does managed care, has a role in at least promoting this additional education? Because you must see that the changes happening in the delivery of behavioral health services. So does managed care has a role in promoting greater training or offering greater training?
Managed care, like Centene, is very committed to integrated care. And first, where we have integrated care is internally in our organization. My office was right next to Keith Wilson's office. He's my MD counterpart on the medical side, and I did the behavioral health side. Our offices are side by side. And our care managers, the medical and the behavioral care managers, are integrated together so that they're communicating. And at one point, we had an outside vendor that did our behavioral health managed care. And 5 years ago, we brought it in-house so that we could better coordinate services for people. So the company is committed to internal integration of medical and behavioral health services. That's one thing. And then the second thing was we work with our providers, like I was just saying, to develop patient-centered medical homes among the primary care physicians who engage social workers, psychologists to participate in their practices and provide mental health services side by side with them. And the behavioral health homes, where the community mental health centers bring in primary care as part of their basics package of services at the mental health center. And we think these advances have made a tremendous difference in terms of patient care. In fact, one of the studies we did before the ITN, before the RFP came out for the SMI population, we saw a reduction after we integrated mental health services into the company. We saw a reduction in expense for 3 years in a row as a result of coordinating care for people with mental health and behavioral and medical problems together. It was quite significant.
You know, I agree for a reduction in cost, but also an improvement in outcomes.
Oh, we're seeing our quality scores are going up every year. In fact, in Florida, we were the first plan in the WellCare system to reach a 4.0 quality measure score for stars in the state. So that was a huge, you know, the star rankings go from 1 to 5, and we were the first one to develop a 4.0 star score measure. So we are seeing quality scores go up. And now part of our contract with these behavioral health homes is that we feed them information about the star scores and the quality measures, NCQA quality measures. And so every month we have a meeting with them around all of these measures that need to be fulfilled for patients to raise their quality score. And many of those are preventative measures, like getting, you know, pap smears, breast exams, blood pressure monitoring, and all of that.
Yeah. So, you know, going back to the integration issue, I think, you know, from what sometimes I hear going on the outside is that seems to work for maybe larger practice, but what happens to the smaller practices? How do they promote, or how do they start integrating? You know, you are 2 or 3 providers in a smaller practice. So they're not part of this larger group. They cannot afford to hire, you know, even a part-time mental health person or psychiatrist. What suggestion would you have for them to be able to participate in these integration efforts?
Well, we provide them with all of the data. Even small practices, we can provide them with the data. And then we have quality staff that go out and meet with them and help them, you know, figure out how to attend to those patients, make them aware of the quality score of people with low quality scores and so on. And so it's a very individualized approach where we call them a quality practice advisor, QIPA person, who goes out and meets with the provider, large practice or small, and helps them navigate these measures so that they can be successful. And then we have pay for performance programs where they actually get reimbursed at higher rates for meeting quality scores, quality standards. So it's an incentive to the provider, and he can have his staff do a lot of this work in the office to get the patient in, get them seen, get these services completed, like well baby services or physical exams or whatever's needed. So we provide a lot of support for that.
But there's those small providers in the small practices. I mean, the personnel that you have, the staff going to visit the smaller practice, can they help them in says, well, here are the psychiatrists in your area that will accept new patients or patients? Can they help them at connection?
Yes.
All the time, you know, and that's what we get on a hotline, or for example, a child psychiatry hotline. These providers have absolutely no clue where to go, how to connect with the behavioral health.
Yeah, well, you know, I don't think it's so much the provider. I think in many cases it's the patient. You know, so many of our patients through Stay Well and Sunshine, we can't connect with them in any way. We can't contact them. We can't find them. It's like they're living on the streets, or they're bouncing from one friend to another, or they're living in a car. They don't have a cell phone. So this is a subset of the population that it's so difficult to find them and connect with them. That's really the challenge that we as a managed care organization doing Medicaid and Medicare have, is reaching out to these people and finding them. telepsychiatry has made a huge difference for a certain subset of the population. Like if you're a single mom and you've got 3 kids at home and you don't have transportation, you need a ride to the hospital. A lot of our community mental health centers now, in fact, the majority of them are using telepsychiatry actively. They can reach out to the mom. She can sit at home with her child. The doctor can do an assessment of the child for ADHD or whatever it is, medication management. And she doesn't have to get a babysitter. She doesn't have to call for transportation. It's been a huge benefit to be able to reach out to people by way of telepsychiatry. And we've seen our claims for telepsychiatry just shoot through the roof this past year. Yeah. And it's been a great.
I agree that's a challenge, because in the small telepsychiatry demonstration project that we are involved with currently, connecting with that population is an issue under the best of circumstances.
Yes.
For the reason that you said. So even though we offer them the telepsychiatry, we have a lot of missed appointments.
Yeah.
And missed appointment, having to reschedule forever, or changing their mind at the last minute, or phone is disconnected. They've moved to somewhere else. So, really serving that population is a real challenge. That we all agree on that. Yeah.
Yes, it's, they have other worries.
Yes.
They worry about where their next meal is going to come from.
Yes.
They worry about where are they going to sleep tonight. These social determinants of health are driving people's mental health issues. Domestic violence, alcoholism, opioid abuse. They don't call you back because they're intoxicated or, on an opioid and don't answer the phone, or they're so paranoid they're afraid to answer the phone. So the social determinants of health are a huge issue, and our company's really doing their best to try and address those. We have a hotline set up for people to call when they need a resource. They can call and get some help finding a resource. And we have hundreds of people calling, and it doesn't have to be a Sunshine or a Stay Well patient to call this community helpline.
It's open to all. That's great. That's fantastic. That's really good.
Yeah.
So.
And it's and you can find it under communityresources.sunshine.com, and the phone number is 877-247-6272. If people need to call that number and get a resource, they're welcome to use it.
And they can also contact us, and we will provide them with the number as well.
Yes.
Another question that I have that's of interest to me is the coronavirus pandemic represents, really is an unprecedented stressor to patients with serious mental illness and the behavioral healthcare system in general. As a recent article in Psychiatric Time reports that the coronavirus pandemic is the most disruptive force in psychiatry since the institutionalizations of the 60s and 70s. First, do you agree with this assessment? And 2, can you describe a strategy that your organization has put in place to mitigate the negative outcomes of COVID-19 on this vulnerable population?
Well, the company's tracking all the positive COVID cases. They track the patients that are being treated for COVID. We've opened up authorizations. No prior auth is required for any patient that has a mental health condition. The providers do not have to provide documentation of what they're doing with the patient, like for a pre-authorization and that kind of thing. These were all mandated by the state, basically, to make sure that barriers were as low as possible so people could get the services they need. But I think, early on in the pandemic, we saw a huge reduction in the number of people going to the hospital. They were just afraid to go to the hospital, right? They weren't going to the hospital because for fear of getting infected with COVID. So people who needed specialty care, whether it was in psychiatry or other specialties, were not getting the care they needed. And so there was increased morbidity and mortality around those untreated conditions because of the COVID experience. And now I think we're more and more literature coming out just in recent weeks about the longer term effect of COVID on people's mental health in terms of chronic depression, anxiety disorders, not to mention loneliness and isolation and so on. So I think it's going to take quite a long time for us as a society to recover from the COVID epidemic and the losses that we've seen, family members that have passed away in isolation, away from their families, unable to say goodbye to them and so on. And I think it's had an impact on the providers as well. A great deal of burnout, desensitization. Physicians have, I think there's a renewed understanding of how important physicians are to the community now, that physicians, nurses, nurses' aides, these people that are on the front line of caring for people, what they do for the community, how much they mean to the community. And every time I talk to a physician on the phone now, I thank them for their care of the patient, thank them for being out there in the community, putting themselves on the line to see these patients. It's
Do you
impressive.
think that it has been especially difficult on the mentally ill population? I mean, it's been difficult to everyone. That's so true. But this particular population has issue to start with access, or because of their perception of their mental health perception, have had a particularly difficult time and in even keeping up with the basic services they received. If you recall, at one point, everything was closed, so this patient may have missed appointment, missed medication, and all sorts of other services. So do you really think that this population has been particularly badly affected?
Absolutely. Like, they're difficult to keep in treatment in the first place, right?
Right.
80% of the patients don't take their psychiatric medications 60% of the time. And that's under normal circumstances. So here you have these very difficult circumstances, and patients who are lonely, isolated, paranoid, depressed, alone, that whole thing is exaggerated by the COVID epidemic. And I think it's important to point out that the recent research shows, they talked about the risk factors for getting COVID as heart disease and some other things. Well, now they're saying really clearly one of the risk factors is mental illness, mental health problems, 30% higher rate of catching COVID than a person that doesn't have a mental health problem. So they're at risk and they're more vulnerable. And so I have to give credit to the mental health centers who stayed open during this pandemic, who, really experienced some financial hardship during the early months of this pandemic, where all of their services were shut down. And then, they had to get on top of this telepsychiatry service early in the process. It was a humongous effort, and these real shift in the way they provided services, and I really, my hat's off to them for taking this on and doing all they did to keep their patients safe and engaged, keeping them in treatment where they could, but it is a difficult population, even under the best circumstances. And here we had the worst circumstances.
Right.
So,
correct. I agree. I totally agree. Just one last question. So, when looking at the future, many are looking at a shift in the way healthcare in general is delivered, mostly propelled by digital health and other factors. Can patients with behavioral health conditions be empowered to assume a greater share in managing their condition? I'm thinking about shifting more care to be delivered in the home rather than in a traditional office setting. As you mentioned earlier, transportation is often an issue. How would a patient with a serious mental illness manage this transition?
Well, I try to identify the people with SMI, and we encourage them to participate in a behavioral health home. We ask them if they would like to participate in behavioral health home. Our commitment to the state was that 50% of our SMI population, which is now around 120,000 members, so about 60,000 people, would be in behavioral health homes by the end of our 5-year contract. That's our commitment to the state to try and make that happen. Of course, it's up to the patient to do that. But we think it's in their best interest. And if they don't do that, we're trying to help them find a primary care physician who has a patient-centered medical home that, provides mental health services in their primary care office. But, like I said, I think primary care will provide care to 80% of people who have some sort of mental health diagnosis. Mm-hmm. And the other 20% go to a community mental health center who have a more serious condition and who need the continuum of care. They need all of the services that a mental health center has: day treatment, PHP, clubhouse, peer support, long-acting injectables, and all of that. So that 20% would go to the community mental health centers, and primary care physicians take care of general anxiety, general depression, marital dysfunction, ADHD, pediatricians treating ADHD, pretty much standard course of treatment now. So that's where I see this going.
Clearly, we as stated in a Bob Dylan song, the time is very changing, really, and never more so than now, where it's almost improvisation, trying to find the best fit for each patient, which is not an easy task to do. So I certainly, we appreciate all of what is done in community mental health centers, and definitely the greater role of primary care providers. So, in other words, in a few words, where are we headed? Is it good?
Well, I think your organization has done a tremendous amount to educate primary care physicians in the way of those best practices, and I think the state has mental health services at the very top of their agenda. And I think the state needs to be acknowledged for their efforts in the area of mental health in terms of developing FACN teams, mobile crisis teams. They've funded housing for people that are homeless in recent 3 years. They're encouraging long-acting injectables, and it's part of the formulary now, the state formulary, that all long-acting injectables are on there, I think for the most part, with 1 or 2 exceptions. And peer support, they pay for peer support. So we pay for peer support through our health plan. And Clubhouse was never paid for before, and now it is part of our service repertoire. They're paying for equine therapy and art therapy, activities, kinds of therapies that really make a difference for some patients. So I think there's a broadening, growing understanding of the importance of mental health in the total care of the patient. It's more of an integrated, holistic approach to patient care now that didn't used to exist back in the 80s when I first started in practice.
Yes. Well, I think, there's certainly, in my humble opinion, much to really be grateful for, in the progress of the delivery of mental health services. And at the same time, we need to keep at it, or keep
the pressure on, right? Keep the pressure on. There's a lot more to do. We're not anywhere near where we need to be. The state of Florida can continue to improve. They're not in the top 10 states in mental health funding. It'd be great to see them in the top 10. Maybe it could happen, but I think that we're moving in the right direction. And NAMI, I'm on the board of NAMI, and I've been proud to be on that board. They're the advocacy group across the state. We just recently had a conference, a virtual conference. Over 700 people registered for the conference. Our company was a major sponsor of that conference, and it was hugely successful. I know you got a special award from NAMI for your contribution to mental health, and we really appreciate that, Marie, all that you've done for mental health in Florida.
Well, we're grateful to all of our providers. Definitely, I'm very grateful to you for agreeing to be our first interviewee in a series of various addressing different types of behavioral health issues. Thank you again, Dr. Abid. I'm very grateful for your participation in this interview.
I'm your test case today.
Yes, you are, and a wonderful one. Thank you again.
Thank you. Thank you.
Bye-bye.